So we are going to show you guys how to manually prone patients with ARDS. We have 4 checklists here. Phase 1 is the pre-prone checklist. It's getting your patient ready to be proned. So we'll go over the most important things, but everything else you can read on your own. Phase 2, executing the prone position checklist. This one is when you're actually performing the maneuver. It has all of the steps to take to flip the patient into the prone position. Then there's a small section, steps for manual supination, so when we're flipping the patient back to supine position. And then there is a phase 3, care of the patient while prone. So it's just kind of reminders of nursing care, things to look out for while the patient is prone. And the phase 4 checklist is care of the patient while they're supine. So with this therapy, they're going to be prone for 16 hours and supine for 2 to 4 hours. So these are additional considerations while the patient is supine. We also have a consideration section here at the end, just to kind of remind the team of things that they would want to do prior to the first proning cycle. So it's all based on physician discretion, but we placed them here to kind of prevent delays in proning. So moving on to the first checklist, phase 1. This most important thing here is if you have a patient that's going to get all the lines placed, you want to make sure that all of the lines are on one side of the patient, whether that is the right or the left, and that is because you are going to use the other side as your pivot point to flip the patient from prone to supine. If the patient does come from an outside hospital with lines in different places, it's not a contraindication. It's more for us to be able to access the lines. And that's why we would like them on the one side. Again, it's on a case-by-case basis. If a patient needs to be proned, it's not a contraindication. The other thing you want to do is, let's say all of your lines are placed on the right side, you want your ventilator on the left side, and vice versa. Once you move the ventilator to the appropriate position, you don't have to move the ventilator for any more cycles. So those are the main things for the phase 1 checklist. This here also tells you where to put the Mepalexes on. We're going to prep the patient, do a CHG bath, do a second nurse check with the skin before we flip them to the prone position. We are also going to sedate the patient, but we don't have to sedate them to a RASS of -5 and paralyze them. So the new guidelines state that as long as the patient is synchronous with the vent, that's mainly how we're going to titrate our sedation. So you're going to work with the respiratory therapist, and they will let you know if the patient is synchronous or if we need to go up on the sedation. We'll go from there. Most of the time, we haven't had to paralyze our patients so far, but there has been times where if you do paralyze, you have to sedate them to a RASS of -5 and then paralyze. They can get dysynchronous afterwards when they are placed in the prone position, so you can again, start off the sedation, prone them, and then finish off the sedation. So it just all depends on what they're doing on the vent. So there is some things here for the respiratory therapist as well. The main thing, if you want to talk about the ETAD versus the Dale holder.
Yeah, so we'll come in and we'll switch from the ETAD that everyone is used to seeing. That is just shown to cause skin breakdown. So we switch it to this cloth Dale holder. And what we will be doing on the actual patients, we'll put the 2x2 Mepalex like this underneath the Dale before we place it, just for added protection on the cheekbones. You don't necessarily need to have them on the forehead or the chin, because we found that it's really not a pressure point. After you prone and you find areas that need a little more padding, you just add some more as you go.
The tape on the ETAD sometimes causes the skin breakdown, and
Yeah,
that's why we
that's
place the foam dressings underneath the cheeks and then the Dale holder on top of that, and it's worked well for us. Okay, so we can go ahead and move on to the phase 2, performing the maneuver, executing the prone position checklist. Here, there's roles for the charge nurse, the respiratory therapist. So in an ideal situation, you would like to have 7 people, 5 to 7 people, but again, it all depends on the size of the patient and the availability of staff. So the charge nurse is going to be in charge of gathering the turning crew. The turning crew consists of the respiratory therapist. The charge nurse is hands off and she's reading the steps for the manual pronation procedure. And then you have 2 nurses on each side, and the doctor would be just hands off watching the monitor. Right now, given this current situation, we are trying to limit staff exposure, so we have been doing it with 4 nurses and 1 RT. We did it with 3 nurses and 1 RT for this last one. So again, it all just depends on your comfort and the size of the patient. So the first thing here is the respiratory therapist is going to pre-oxygenate the patient with 100% O2, just to kind of get the patient ready for the maneuver. Then the charge nurse will start with step 1. So step 1 is to ensure that the lines and tubes found from the waist up are positioned towards the head of the bed, and the lines and tubes from the waist down are positioned toward the foot of the bed. So you want to get those as close to the head and the foot as possible. You may need to grab your IV pole and pull it by the RT. You may need to grab your monitor and also hang it with on the IV pole, just to make sure you have enough slack. Yeah, and then just try to get those as much, yep. The next step is ensure enough slack is present, especially with the vent circuit. You want to make sure you don't want the vent circuit to disconnect at any point. So making sure there's enough slack there. Next, you want to maximally inflate the bed and place it in flat position. Increase the height as needed. It looks like it's at a good height for you guys right now. The next step is we are going to place a maxi tube underneath the patient. Place it as underneath as possible, so you guys can get rid of the side rails here. Perfect. Now we're going to remove the patient's gown, the EKG leads, and the stickers. Make sure you remove the stickers. At this point, we are going to so most of these patients are getting arterial lines, central lines placed, so we're going to use the arterial line for a pulse. As of right now, we won't be monitoring the rhythm. We also have the SpO2. We have also been taping the transducer to the side of the chest. So removing it from the arm and just taping it to the side of the chest so that you can continue to have a pulse throughout the whole maneuver. Next, we are going to tuck the patient's hand that is closest to the ventilator underneath the patient's buttock with the palm facing up. Now we are going to place underpads, chucks on the patients, and this is just to kind of, if your patients are sweaty or they have any kind of moisture, this will be below and will trap the moisture. Next, we're going to place pillows on top of the underpads, and the idea behind this is you want to offload and kind of offload the abdomen as much as possible when the patient is in the prone position. So you want one on the chest, one on the pelvis, and one on the knees, and so the abdomen is floating. Depends on the size of the patient. Sometimes they do require more than one pillow because you would like this to be as flat as possible, since that's going to be the side that is prone. Next, we're going to grab a flat sheet and we're gonna put that on top of the patient. We're going to cover the patient except for the head. Now we are going to roll the top sheet and the bottom sheets together like a burrito, kind of encasing the patient as tight as you can. And this will help us keep all the lines in place, keep the pillows in place. So you do want to tuck it as tight as you can. Perfect. At this time, at the RT's request, if they would like the patient to be boosted up a little bit, all of the maneuvers from here on out will be on the RT's count of 3. So before we move on here, we want to make sure that the respiratory therapist is holding on to the neck and the occiput to stabilize the backside, and the ET tube and the face with the other hand. That way, wherever the face goes, the respiratory therapist is going with it and it's not extubating the patient. So if he would like, we can boost the patient. It's up to you.
Sure, let's boost.
On your count of
We're
3.
on the count of 3. 1, 2, 3.
Perfect. Now on his count of 3, when we prone, 2 things we need to do. We need to always move away from the ventilator and always have the endotracheal tube facing the ventilator. So in this case, we're going to move horizontally farthest away from the ventilator on his count of 3.
Everyone ready? 1, 2, 3.
Perfect. And just remember this whole time, the respiratory therapist is holding a heavy head, so the movements, you want them to be as slow as possible and on his count of 3. So the next move is to place the patient in the sideline position, 90 degrees. On your count.
So on my count, 1, 2, 3.
Sometimes these patients need to be slid over a little bit before they are placed in the prone position. So on his count of 3.
So we'll slide over towards the window on my count, 1, 2, 3.
Perfect. And then the last move is to you two, Lance and Ellie, will be grabbing the bottom sheets together and kind of pulling the patient while you guys help the patient go into the prone position on his count of 3.
Everyone ready? 1, 2, 3.
Perfect. And now you can remove the maxi tube, you can remove the sheets. At this time, you can fix the pillows underneath so that you're making sure that there is one pillow underneath the knees, underneath the chest. You want to offload the toes, and we have been using wedges. Offload the toes here. If the wedge, yeah, and that way it sits. And we have been placing foam mechalexes here because this is a pressure point, just to be extra cautious. Make sure you have the knee mechalexes, and then before we place the patient in the prone position, we have also been removing the stat lock from the front, taping the Foley to the side of the leg, and then placing a new stat lock back here, so that also doesn't cause any pressure points. This transducer is going to stay on the chest, taped to the chest, and that way you will always have a pulse. And then the respiratory therapist will, and I'll let you speak on that. You place the EKG leads back on the patient's back, and then
So we'll be doing what we call the swimmer's position with these patients right now we're gonna do 4 hours. We're working with PT about their recommendations. So the swimmer's position is the arm that is opposite the direction that the head is facing will go up. So facing left, right arm will go up, facing right, left arm will go up. So we'll be coming in and doing this every few hours just to prevent brachial plexus injury, and we will be documenting this in EPIC. We're working on a flow sheet at this time, but.
and we've also used this time as nurses because sometimes, most of the time, they need help if the patient needs to be boosted a little bit, or if the chest needs to be elevated, we would help elevate this a little bit while he performs the maneuver. With patients that don't have a neck, it's easier if you boost the patient, so that his neck is floating and it's easier to.
1, 2, 3. So we'd float the head on some of those tougher patients. Give me some clearance to turn the head. And then on the count of 3, we'd come back down. 1, 2, 3. Good.
We've been placing fluidized positioners. Those are the best ones right now because you can, depending on the patient's pressure points on the face, you can push down on it so that you can have access to see both eyes. If some patient's nose is on there, you can just push that down. So you want to try to see as much as possible. We have been placing foam dressings on the ears so that when they turn, that is protected. And the bed needs to be in reverse Trendelenburg, -10 to -20 degrees. That's just going to help with decreasing swelling and the secretions, buildup of secretions. What else? You can place additional lines if needed. That's again at the doctor's discretion. But if they need any additional lines, they can be placed in the prone position. And physicians have performed bronchoscopies on prone patients as well. Again, that's on their based on their level of comfort.
Can they get tube feeds because their head's not up?
Yes. So the recommendations for nutrition here at Rush did state that as long as the patients are on low pressor requirements, they can get trickle feeds, and the dietitian will be consulted to perform an assessment, and based on their electrolytes, their fluids status, they will place what it is that we need. Our patients have been on high pressure requirements lately, so we haven't been able to do that, but if they're going through multiple cycles of prone and supination, it is advisable to do tube feeds even if it's trickles. They all have OG tubes, and we are still giving them meds by mouth, by the OG tubes, so that's another good option.
What about aspiration?
That's another reason why we want the bed -10 to 20 degrees to kind of help prevent aspiration. We haven't had any issues with aspiration, and we are giving the antiviral medications right now. So, and they're all tablets. So.
How long do you prone them for?
The recommended proning cycle, this is based on the ProSiva trial, which solidified the whole proning as a standard of care, recommends at least 16 hours. So we have been leaving them in the prone position for 16 hours. And then we supine them 2 to 4 hours. And after 1 hour that they have been supine, we will check an arterial blood gas to see if they've improved or if they've gotten worse. And based off of the arterial blood gas, we will either go back to the prone position or leave them supine. And we are checking ABGs daily. We have had a few patients that have had to go prone again after 2 days of being in the supine position. We are right now proning if they have PF ratios of 150 or less. So that's moderate to severe ARDS.
That is your PaO2 divided by the amount of the FiO2 that you're on. So if your PaO2 is 60 and you're on 50%, it's 60 divided by 0.5. So that'd be a PF ratio of 120, which would be moderate to severe ARDS, and we'd most likely prone that patient.
Mm-hmm. And that's what we're trending to decide on whether they need it.
And while in this position, are you adjusting the wedge?
Yeah, so what we've been doing when the respiratory therapist goes in to do the head and the arms, we have been placing pillows or wedges here, and that counts as our turns as well.
Okay.
I will say it is helpful to place your wedge on the same side that the face is facing. So this way I would face it over, I put it under here.
And then it allows
the head to turn a little more.
Yeah.
As opposed over there, then the head is working against itself.
So you're turning the head periodically as
Every
well
4
as?
hours.
Every
yeah.
4 hours, yes.
Well, the head and the arms, yeah.